Patrick, a 78-year-old patient, is suffering from COPD and left-sided heart failure. The respiratory symptoms he has are dyspnea and coughing. During left-sided heart failure, the pulmonary veins attempt to carry oxygenated blood from the lungs to the heart but experience a backflow effect, which leads to pulmonary hypertension. The increased pulmonary hydrostatic pressure pushes fluid from the pulmonary capillaries into the interstitial spaces and enter the alveoli, causing pulmonary congestion and edema. The excess fluid induces coughing and reduces normal oxygen flow, causing dyspnea. In emphysema, the destruction of alveolar walls decreases the respiratory membrane surface area, therefore reducing the capacity for gas exchange and causing hypoxemia. The loss of elastic recoil reduces the passive expiration and allows air trapping to occur, causing hyperinflation. This adds workload onto the lungs and leads to dyspnea and fatigue. Furthermore, during chronic bronchitis, the mucociliary escalator's ability to clear excess mucus from the airway is compromised. The weakening of respiratory muscles related to COPD also reduces the effectiveness of the cough reflex, which further worsens obstruction and limits Patrick's expiration. Normal heart rate stands between 60 and 100 beats per minute. Patrick's tachycardia of 155 beats per minute is due to both heart failure and COPD. During heart failure, the heart's ability to maintain stroke volume is decreased. According to this equation, to sustain a sufficient cardiac output for tissue and organ perfusion, the heart must pump faster. Furthermore, COPD patients would normally have hypercapnia progressing to severe hypoxia. When the central and peripheral chemoreceptors detect an increase in carbon dioxide, they send afferent nerve impulses to the respiratory centers. The chemoreflex is triggered and activates the sympathetic nervous system, SNS, therefore his heart rate is increased.
Whilst COPD and left-sided heart failure have similar symptoms and signs, they also have a common significant modifiable risk factor: cigarette smoking. Nicotine is a potent vasoconstrictor that can cause hypertension. With Patrick's extremely high heart rate, a much higher blood pressure will be expected. However, his left-sided heart failure, which substantially reduces his cardiac output, and thus his blood pressure falls in the normal high rather than hypertension category. Smoking may also increase LDL level, decrease HDL level, contribute to blood vessel endothelium damage, inflammation, and thrombosis, leading to atherosclerosis. Atherosclerosis can block coronary arteries, causing myocardial ischemia and infarction, which can progress to heart failure. Smoking develops COPD by either triggering a remodeling process, which leads to alveolar destructions and loss of elastic recoil of bronchi, or causing chronic airway inflammation, which eventually results in hypoplasia of goblet cells, hypertrophy of mucous glands, and injury of ciliate epithelium. The impaired mucociliary escalator is ineffective in removing the increased mucus production, leading to chronic airway obstruction and intensifies the expiration difficulty. Therefore, Patrick's COPD is related to the airway anatomical change caused by his previous smoking history of 40 years and is independently developed from his left-sided heart failure. However, COPD can exacerbate left-sided heart failure and vice versa. Hypoxemia due to COPD can trigger SNS and increase catecholamine release to increase heart rate and contractility, which imposes more workload onto the already damaged ventricle, with the heart's oxygen demand further increased. SNS also stimulates the renin-angiotensin-aldosterone system RAS, the antidiuretic hormone secretion, and the endothelin production, leading to vasoconstriction and water retention. These increase blood pressure and venous return to the already overloaded heart. Additionally, COPD is associated with the release of pro-inflammatory cytokines, which can cause systemic inflammation and worsen heart failure. Collectively, these hormones and inflammatory molecules facilitate ventricular remodeling process and thus deteriorate his heart failure. His left-sided heart failure, on the other hand, aggravates his COPD by its backward effect, which causes pulmonary congestion and edema. By having both left-sided heart failure and COPD, Patrick is currently at a high risk of developing right-sided heart failure. Alveolar hypoxia due to a ventilation-perfusion mismatch occurs during COPD, stimulates pulmonary vasoconstriction, a compensation mechanism of the body to increase blood flow for oxygen exchange. However, chronic alveolar hypoxia causes vascular remodeling. Moreover, alveolar destruction due to emphysema decreases the amount of pulmonary vascular bed. These two factors can increase the pulmonary vascular resistance and subsequently lead to pulmonary hypertension. Left-sided heart failure also causes pulmonary hypertension via its backward effect, pulmonary edema. Pulmonary hypertension increases the resistance to right ventricle emptying. In other words, it increases right ventricular afterload. To compensate for the chronic pressure overload, the right ventricle will have to work harder, which progressively leads to a myocardial hypertrophy. The thickened myocardium has a higher oxygen demand and thus more likely to experience ischemia. This enhances collagen deposition between myocytes and over time decreases the right ventricular contractility. Reduced ventricular contractility increases end diastolic volume. To cope with this increase of blood volume, the right ventricle will dilate gradually, leading to myocardium overstretching and sarcomere dysfunction, which further reduces the right ventricular contractility. Therefore, although ventricular remodeling is an adaptive mechanism to pulmonary hypertension, it will progressively weaken the right ventricle and eventually result in its failure. Reduced renal perfusion due to insufficient cardiac output because of Patrick's left-sided heart failure may lead to renal damage and failure. This disturbs the regulation of sodium and potassium excretion, reduces calcium reabsorption from intestine, as the conversion from vitamin D into calcitriol is inactivated, and decreases hemoglobin count due to a reduction of erythropoietin synthesis for erythrocyte production, consequently causing his hypernatremia, hyperkalemia, hypocalcemia, and anemia. RAS activation further potentiates his hypernatremia by its sodium and water retention effect. Moreover, with his COPD and heart failure, Patrick is constantly under hypoxemic ischemic state, which increases his acidosis and cell necrosis risk. These can also contribute to hyperkalemia. The imbalance of these essential electrolytes for action potentials and synaptic transmissions will affect Patrick's neurological function, ranging from restlessness to detrimental effects such as seizure and coma. Anemia-related oxygen deficiency can cause dizziness, fatigue, and numbness. Patrick's low HDL but high LDL and triglycerides indicate dyslipidemia, which makes him susceptible to atherosclerosis and the development of stroke. Common signs of stroke include unilateral paralysis, aphasia, severe headache, and visual disturbances. With left-sided heart failure and COPD, Patrick's likely to experience hypoxemia and other stresses that stimulate the release of catecholamines and cortisol. These enhance gluconeogenesis, glycogenolysis, and reduce insulin secretion, leading to hyperglycemia. However, with his central obesity, dyslipidemia, and hyperglycemia, Patrick is at risk of type 2 diabetes. Therefore, confirmation with glycated hemoglobin level test is recommended. Uncontrolled hyperglycemia can damage neurons and result in diabetic neuropathy.
Patrick's left-sided heart failure is likely to have reduced renal perfusion, therefore impairing his kidney function. An additional blood test that is likely to support this theory and show abnormalities consistent with left-sided heart failure is creatinine serum levels. Creatinine is the metabolized waste product of creatine, which gives muscles energy. Creatinine travels through the bloodstream and is filtered by the kidneys and excreted into the urine. The normal serum values for creatinine in adult males is between 0.06 and 0.12 millimoles per litre. A creatinine level of 0.5 millimoles per litre or more in the bloodstream indicates that there is severely impaired kidney function or kidney failure. Therefore, a high creatinine level is expected for Patrick.